Thank you so much. I'm sorry I couldn't be in Argentina today and have some nice food or something. Nice steak.
Yes, that's true.
Have a great day.
So, well, some in the near future, we might travel again and we might be able to see each other.
Oh,
So
I hope
take
so.
care, and I think I wish that everything is okay with your family.
Yeah, thank you. Bye.
Bye-bye. Bueno, continuando la sesión, es decir, tenemos que, ahora cambiamos de la parte de implementación y pasamos a la parte de informática pediátrica, pero también está relacionado con implementaciones. Y tenemos al doctor Chris Lehmann. Chris Lehmann es pediatra, hace informática médica hace varios años, y como lo ven está también con está vestido de guardia porque él trabaja de neonatólogo, también está en Texas, y nos va a dar una charla sobre 20 años de experiencia de calidad y seguridad en sistemas de información orientados a pediatría. Introduction about that you're not only working on health informatics, but also you're a neonatologist on call because you have your scrubs on, so you're working at the hospital. So let me just share, because now, let's see if it works. So, yes it does. I'm going to start, I'm going to share my screen. And we go right ahead with the talk.
Buenos dias. My name is Chris Lehmann, and I'm joining you today from UT Southwestern Medical Center in
just let me check if everything was okay. You were able to hear yourself, Chris?
Yep.
Good. So we can continue.
Dallas, Texas. I'm excited to be able to be part of your conference, and I would like to thank my friend, Paula Otera, for the opportunity to talk to you today. I'm happy to share with you today my experience over the last 20 years in pediatric informatics. Our talk is entitled, Making Patient Care Safer, More Effective, and Cheaper. A little bit about me. I'm the director for the Clinical Informatics Center at UT Southwestern. I will lead its Clinical Informatics Fellowship and its Master of Science in Health Informatics. I'm also the editor-in-chief for the journal Applied Clinical Informatics, and I'm the immediate past president for the International Medical Informatics Association. A few years ago, I did what we call Google surfing or ego surfing, and I looked myself up on Google on the image search. And I realized when I was searching for making care safer, my name popped up, and I was very pleased, or my face popped up, and I was very pleased with that. For 20 years, I've used clinical informatics to make patient care safer. Healthcare is inherently dangerous. This chart has on the x-axis the number of encounters for each fatality, and on the y-axis the total lives lost per year. If you look at this, European railroads, the further right you are, the safer are very safe. And healthcare, which you see on the top and pretty far left, is only slightly less dangerous than mountain climbing and bungee jumping. I got into informatics by a very sad and tragic episode. I was working at Johns Hopkins when Josie King died. And Josie's death was not the fault of one doctor or one nurse or a mathematical error. It was the result of the breakdown of our system. It was a lack of communication and not listening. And it was a combination of many errors, and most of them were avoidable. In 2001, one of my medical residents made a mistake that overdosed one of my patients by a factor of 10. And I realized at that point that informatics could bring solutions. When Josie King died, her parents sued Johns Hopkins Hospital, won, and they immediately took that money and turned it around and started the Josie King Foundation, which supported a research team for patient safety. So Josie's death opened the doors for me to be part of that team and to use informatics for patient safety. All my career, I've asked a series of questions that show us potential ways that informatics can influence how we take care of patients, how we shape the future. What if we could determine how to make the electronic health record more intuitive and effective for clinical care teams? What if we could design, actively implement applications that would help people with their health and healthcare? What if we could design data-driven strategies that allow for efficient clinical practice without adding the additional burden to the clinical practitioners? What if we could develop products and applications that reduce the cost of care? What if we can collaborate with others to use data analytics, machine learning, and data science to increase diagnostic quality? What if we could use informatics to reduce physician burnout or nurses burnout? Chuck Friedman from Michigan came up with a Friedman's rule. Man and machine together are better than man alone. While Lehmann's axiom says machine and man together are better than machine alone. What do I mean when I say that? Well, we make mistakes in very different fashions. Humans have significant weaknesses. I'm terrible at repetitive tasks. I don't have attention to detail. I get easily distracted. But I have also some strength. I have imagination. I'm really good with unforeseen events as a human, and I'm flexible. Machines, they don't have imagination. They're terrible when something unexpected happens. They lack flexibility because we haven't programmed them to be flexible. But they're really, really good at repetitive tasks. They can focus like nobody else. Nothing can distract them. So together, we can create a symbiosis of man and machine that improves on our ability to take care of patients. So I'm going to move you through a series of examples of safer, more effective, and cheaper. And these are all examples that we developed over the last 20 years and where we had the opportunity to evaluate them. First one is a story of a move of a hospital. In 2012, the pediatric hospital at Johns Hopkins moved from an old building into this brand new tower that you see there. You know, while there's a lot of media coverage when a hospital moves, nobody has really ever studied it, what the effects are on the hospital's health. Our hypothesis was that our electronic health record could measure the health of the hospital. So how did we go about to do that? We used the medication, ordering, dispensing, delivering, and administration as an example, because this process requires good communications and collaboration that might be disturbed if you move a hospital. So we took the time it took from ordering the medication to the first dose to measure the health of the hospital. And our findings were very surprising. Well, we expected a significant improvement that we saw in psychiatry because we completely revamped the medication process as part of the move. And then for the rest of the hospitals, we didn't see much of a change, except for the PICU. In the pediatric intensive care unit, we saw that the time from ordering a medication to the first dose increased by over 200 minutes. So that was a real surprise to us. And you know, the reasons why that actually happened are in another talk. They're too much for this talk. But needless to say, we were able to immediately identify that there was a problem, and we were able to use that data to actually change the medication process around the PICU and improve it again. Another example of making care safer was our parental nutrition calculator. The first attempt was in 2001. We developed a calculator for the NICU. and within a month, everybody in the hospital was using it. It spread virally. Why did it spread? Because it saved an enormous amount of time for the physician. Reuse. It's a simple tool, a web-based form that you would log into, and you could pick data from a previous day and modify it. And the form would do all the calculations for you what was potentially wrong. The physician could always override it. What did we find? Well, during the control period, we had almost 11 calculated errors went. And if you look at it in the intervention period, we reduced the osmolality issues, we reduced knowledge errors, there were no more bad calculations. We also introduced a new error. We had incomplete orders because we had forgotten to add a reference number to each of the orders. Well, we fixed that. We can say the page number was missing. And once we fixed that and made some other tweaks, within 3 weeks, we were able down to osmolality issues being reduced by 90%. Insufficient fluid was, for the most part, eliminated. Knowledge errors and calculation errors were gone. And our incomplete problem was also gone. So that was a very satisfactory experience. That application lived for data for that, but we were able to also improve the correctness of orders and the quality of the ordering significantly. Another example of making care safer was with pediatric chemotherapy. We had a high pediatric chemotherapy error rate. We were bordering on joint commission violations. And we decided to go and do a failure mode and effect analysis. In the failure mode and effect analysis, you look at all the things that can go wrong, look at the probability that they might happen, look at the probability that they could be identified before they harm a patient, look at the damage that they can do, and you give all of this a numeric value, and that way you can decide what things you have to focus on when you try to address the problems. So we created our own homemade chemotherapy ordering system based on our failure modes and effect analysis outcome. And we were able to drastically reduce the problems with incorrect order format for the treatment plan and for the order. And we assured that the order and treatment plan matched. We had the correct calculations. We had a nursing checklist present. Initially, the order and treatment plan match was not sufficient, and we had to redo it, which was something that we hadn't discovered in our failure mode in effect analysis. So you can see here the data from the 2 different periods. More effective and efficient. Chemotherapy order and wait times. If you have chemotherapy, you don't have time to waste. You want to spend as much time with your loved ones and your family or the things that you like to do. You don't want to be sitting in waiting rooms and waiting for chemotherapy. Plus, it's not healthy. You get exposed with your weakened immune system to other patients. So we looked at the way we were producing chemotherapy at Hopkins. And it turned out that patients were waiting long times. And that was a function of pharmacy starting to prepare the chemotherapy based on the schedule of the patients. So the first patient that was scheduled for the day, his chemotherapy was produced first. The last patient scheduled, his chemotherapy was produced last. Well, we changed the trigger for the chemotherapy preparal. If a patient only needed to arrive in order to be good to go for chemotherapy, then his arrival would trigger the building of his chemotherapy. If the patient needed to make counts, the laboratory results would trigger the preparing of the chemotherapy. And that reordered the chemotherapy list. As a result of that, we significantly, by phase 3, reduced the waiting time by 30 minutes per patient on average. And we wasted a lot less chemotherapy because patient 1 who needed to make counts when he arrived, we would wait until the counts were indicative that he could take the chemotherapy before we prepared it. So we had to waste less of it. Another example of more effective and efficient care is our ICU discharge tool. So in the PICU, we were constantly on flyby. Flyby means we couldn't take any patients that came from the outside as a trauma, for example. And we wanted to know, can we better predict how many patients we will have? Because frequently we found ourselves on flyby and then not having any patients in the beds because people were discharged from the PICU. So we know pretty much, we know how many patients we have in the PICU right now. And we have a pretty good idea of who's going to come. You know, we know who's going to get surgery that will require PICU stay. We know the day of the week, how many patients will come in from the emergency room on average. But what we couldn't predict was who was going to leave the PICU. So we were looking for a way of predicting that. So then ultimately we could turn this into bed availability. So we looked at our orders, our active orders, and you see we took a broad look at it. Consults, lab, transfusions, foreign bodies like endotracheal tubes or catheters, and looked at them and tried to build a model that would predict the patient's discharge. And here you see the same patient over a period of 73 hours. On Monday, when the patient has been in the hospital for 6 hours, you can see the model based on the active medications. He has infusion medications. He has nothing but mouth. He's on a ventilator. On Monday, the likelihood that the patients will leave the PICU in the next 72 hours is pretty slim. But on Wednesday at 3, you can see that the infusion meds are gone, the injection meds are gone, the patient's on enteral feeds, he's on a lighter mode of ventilatory support. And you can see the probabilities that the patient will go leave the PICU in the next 70 hours has increased. And finally, on Thursday at 6 a.m., the patient's on a regular diet. He's not on any ventilatory support. He's on enteral medication. And the likelihood of being discharged gets to be very high in the next 24 hours. We used this model and we were able to increase our PICU occupation significantly. And we were very happy with that. And we thought, well, what's the next thing we can do? Well, we could try to get babies home earlier. I threw this slide in. One day I showed up in the newborn intensive care unit and the parents had cut out an image of me from a newspaper article, pasted a Superman ass on my chest, and then put that up at the baby's isolate. And I explained that day to the parents that my superpower were not from being a neonatologist, my superpowers were from being an informatician, being able to do better things for patients through informatics. So the background why we wanted to address the NICU was our length of stay in the NICU increased significantly. And our discharges were frequently delayed for silly things that we hadn't thought of, that we hadn't gotten ready. We didn't get the oxygen to the home. We didn't get the home equipment ordered. We forgot to order the medication that the kid would be on at home. The parent education hadn't been completed. All things that we could have addressed if we would have been triggered to it. So what did we do? We wanted to see, can we predict the discharge date from the NICU? Can we identify what combinations of clinical factors have predictive power that tell us when a patient will go home in the next 4 days? And can we create a simple heuristic that does this prediction fairly accurate? We also looked at natural language note types, the attending and resident features like weight and apnea and bradycardia amounts, the amount of tube feeding, etc. And there were binary features like is the patient on a vent, is the patient on caffeine. We also engineered some features. So the number of days off caffeine, the total feeds by mouth, the PO amount divided by the total weight. So generated those. Obviously, as you can see on this slide, you're closer to discharge. On the right, you're further away from discharge. Certain things were clear predictors of discharge, right? The weight of the patient and the gestational age, they drove the ability to be discharged soon. And other things like caffeine, if you were no longer on caffeine, you were more likely to be closer to discharge, or the number of infused medications obviously had a predictive value. Also, the more of your feedings were greater than 90% by mouth, you were more likely to be closer to discharge. So we created a matrix that had all these features in there, and we created a model using random forest and ran this multiple times, and we were able to create a pretty complex discharge model. You can see we had a probability of 85% to predict the discharge within 4 days. But certain things popped out. The weight obviously always played an important role, the amount of feedings per mouth. You had an 81% probability of leaving the NICU within the next 4 days. So with that knowledge, we actually implemented that, and we popped up decision support help to nurses and physicians. And the results from that intervention are still pending at this time. All right, how do we make care cheaper? Well, our first example is an antimicrobial stewardship program. Antimicrobials are commonly prescribed. They make up for about 1/3 of all administered drug in the hospital. And there are good reasons to restrict them, because unrestricted use of antimicrobials creates resistance and prevents the ability to use them when you really need to use the antibiotic. We had an increasing number of antibiotic approval requests as more drugs became requested. That a prescriber would call the pediatric fellow and ID fellow and get approval. The fellow would then notify the pharmacy. The prescriber would order it, and then the antibiotics were dispensed. And you can see all the places where that could break down. Well, we created a web-based database that the prescriber would enter their request, would text page the pediatric ID fellow, who would approve or deny the request on the web page, and then that information was available to the pharmacy. You can see it looked very similar, simple. This provider is requesting ciprofloxacin, and it has check boxes to indicate why they wanted to do it, but could also provide written responses, and then would provide some contact information. As you can see, we surveyed our providers before and after. Before is red, and you can see and if you look at the satisfaction, the happy colors are green and yellow. People were much, much happier with the system after we implemented it. But what happened that we didn't anticipate is not only did we reduce the number of doses of restricted antimicrobials, but also of unrestricted. Why did that happen? Well, for the first time, we actually took a record of what drugs were approved and for how long. So after 2 days, your vancomycin approval fell off, and you were notified of it, and you had to either request it again, or you had to take it off the patient because pharmacy was no longer dispensing it. And for the very first time, people also discontinued related antibiotics. So a patient was on vancomycin and let's say ceftriaxone, the resin, once the vancomycin approval ran out, also would discontinue the ceftriaxone. So we reduced drug use overall. And if you look at for those restricted antimicrobials, it saved us a significant amount of money. We actually saved $350,000 in the first year at the Children's Center alone. And we followed up 5 years later and were able to show that these savings were sustained year to year. Another way of being cheaper is switching medications from intravenous to by mouth. And so we calculated at Hopkins that if we just created a decision support that would switch medication from PO to from IV to PO when the patient was eligible for it, we could have saved at Hopkins alone, in the internal medicine department alone, more than $1 million. And now here at UT Southwestern, we're actually implementing this. The Children's Hospital is one of the largest purchasers of IV Tylenol. And IV Tylenol is not cheap. It's about $250 a dose. So we are planning a decision support tool that will randomize patients so that their providers will receive a pop-up alert that reminds them to switch IV Tylenol to PO or PR Tylenol. And we anticipate substantial savings to the Children's Center as a result of that. Another example of making care cheaper is therapeutic interchange. At Vanderbilt, we decided to remind providers when they were ordering a certain branded proton pump inhibitor that there were cheaper in-class therapeutic drugs available. And we would pop up this alert, and you can see that an alternative was already checked and would allow people to, in the ordering process, to substitute their medication with another one. And as you can see, when we introduced this in July of 2013, you can see the lines for the triptans, the statins, and for the nasal steroids jump. For the proton pump inhibitors, we introduced it a little bit earlier, and you can see that the response was not quite as strong, but it was a continued improvement. We were able to look at the data of 45,000 members of the Vanderbilt Health Plan. Even though we applied this tool to every patient, we only had the data, the cost data for the Vanderbilt Health Plan. And even though not everyone in this plan was on the PPIs or nasal steroids, we were able to create a substantial cost saving for the members. For every member, we saved $5 per person in the first quarter, or for the total plan, savings of $200,000 by this intervention. So in closing, the Clinical Informatics Center at UT Southwestern leverages 4 tools: education, research, innovation, and service. We are leveraging these things with one mission in mind: making patient care safer, more effective, and cheaper. And now I'm looking forward to joining you live for a question and answer session. I'm really looking forward to being able to talk to you and join your conference. Thank you.
Well, thank you, Chris. I hope that everyone was able to listen to your conference. It was really good. And all the things that we can you can work on pediatrics and of course on oral care. I have one question. Right now you're working at a hospital that maybe has an EHR from a vendor. I guess it must be of the highest vendor in the US. How can you, based on all your experience that was, I guess, done on homegrown EHRs, where you were able to work on what you had your own kitchen where to cook all this? How is the answer of the vendors regarding when the hospital wants to implement some kind of actions like you showed us?
Well, that's a great question, Paula. And let's make sure that everybody knows. I don't think that vendor EHRs are fantastic when they come out of the box. The content of EHRs is generated by the local implementers, as Dean said in his talk earlier. And, you know, it's the implementation, stupid. It's not the EHR. So I have experience both in the vendor provided world. We had Eclipses at Hopkins, as well as a homegrown system at Vanderbilt, but also in a vendor system here at UT Southwestern. And the tools to develop clinical decision support are available in pretty much any EHR. It's how you implement them and how you set them up and what your imagination allows you to create that really makes the difference. I always say what comes out of the box is an F, is a fail. It is how you implement it that either makes the EHR help you save lives and make care better, or makes your physicians' lives even more miserable than it is. So smart implementation of decision support is critical to prevent burnout and is critical to make your patient care safer. And the tools are, I'm agnostic to the EHR by now, but as long as I have the tools to do the things that I want to do. To give you an example, with our vendor EHR right now, we are implementing a decision support that looks if patients are on a diet, and if they are, our hospital happens to be the largest purchaser of IV Tylenol in the US. Now, IV parts, Citamol or acetaminophen is very expensive. And so we are now popping up decision support to remind people that their patients on a diet and might be eligible for PO or rectal Tylenol. And, you know, that's quite easily done with the tools that are available in the vendor EHR.
Good. I have one question from Dean Sitek, and he's asking, do you ever worry about the safety of the EHR itself? Specifically, how do you know whether the EHR is working properly?
Yeah, I worry about things. To give you an example, at a place I worked, I won't mention the names, we did an analysis of clinical decision support artifacts. So what is that? That's order sets, that are alerts, that are reminders, and tools. Anyway, we looked at 3,000 decision support artifacts. And we found that a third of them were either outdated, broken, not used, or flat out wrong. Building decision support is a great way, unless you manage the knowledge, it's a great way of practicing outdated medicine in a very effective and very efficient way. So if you don't keep track of the knowledge that you have implemented in your EHR, you will start hurting patients. So knowledge management is an incredibly important feature to have when you build decision support. So yes, you can injure patients with your EHRs, and people have done it. I mean, you know, I think a great example was the implementation of an EHR at Pittsburgh Children's. Everybody has seen the Hahn paper, but you know, it wasn't a function of the EHR. It was a function of how it was implemented. You know, for example, there was no break the glass functionality. So a sick patient that came in, only after you registered that patient in the EHR could you prescribe medication. Well, that clearly is not good, right? Really sick patients, you need to be able to do things right away. So unless you implement it correctly, that means you will likely run into difficulties and patient safety issues.
Good. We have another question from the audience, from Agustin Ciancaglini. He's a pediatrician. And see have you updated the documentation of pediatric EHR key capabilities?
Have we updated the what? I'm sorry?
The recommendation of pediatric EHR key capabilities. You know, the document that you created 5 years ago.
So we have, we've been working with the American Academy of Pediatrics, and Paula and Guillermo are aware of our efforts. We have worked on pediatric specifications for electronic health records. And currently we're working with a Drummond group, which is a group that certifies EHR for voluntary certification of pediatric EHRs. We believe that if you take care of children, you need to have functionalities that exceeds of what you do with adults. If you take care of geriatric patients, you need a lot of the functionalities that you also need in pediatrics. So we created a set of documentation that outlined what is needed to do pediatric care effectively and safely in an electronic health record. And we are now pushing this out in a certification process for EHR vendors.
Good. I think I have one last question, and you were giving your talk, and all what you said, it sounded so much like artificial intelligence. Do you think that, what would you think of all the algorithms that are around would be good to implement in an EHR that could make it safer and provide better quality and cost savings? Maybe one of each. What would you think?
Well, I'm the editor of a journal called Applied Clinical Informatics. And just today, I rejected 2 papers that just did nothing but machine learning on a data set and creating an algorithm. The vast majority of machine learning that is done these days never gets implemented in an EHR. That doesn't mean we shouldn't try. There are lots of caveats there. There are lots of concerns that I have. We've seen, for example, from lending, from banking, that machine algorithms can introduce racial bias. They can introduce gender bias. They can introduce all kinds of biases that we are unaware of because we don't understand the underlying model that the algorithm generated. That said, I'm a big fan. If you have a project where you actually implement a machine learning algorithm and look how it performs in comparison to no algorithm or an algorithm that's generated by humans, I would love to receive that paper. We don't have enough evaluation on that topic. We need to be really careful what we're doing. If you implement a machine learning algorithm, I want to see you evaluate. Otherwise, you're at risk of doing the opposite of what you intended to do.
Maybe I will send this question also to Dean. What do you think about all these artificial intelligence algorithms and machine learning? Do they actually would pass this rule of what, why, and how?
You know, I really liked Chris's response there about thinking about how things work, and they're so complex, these things, and we don't seem to really understand all the context that goes into them. And so I think you really need to tell about what data you used to train it and how it was used and sort of things like that. So all those aspects of the safer reporting model that we talked about need to go into those AI papers so we can try to assess whether there's some limitations. And so many times, people, pick a small data set and predict something on it, and they never try it somewhere else. So they never check if there's any biases and things like that. And so I think we're gonna have to see a lot more context around these papers, just like Chris, or a lot around the projects, like Chris said, before we're going to know whether these things are going to have the effect that we really want them to have. We've seen a lot of failures in computers in healthcare over the years. Good.
I have 2 questions from the audience, and one is related to what we were just talking about. Josimar Chire is asking, considering the last question about machine learning, how to measure if one proposal is fair enough.
I'm sorry, can you repeat that question?
Yes. Considering the last question on machine learning, how to measure if one proposal is fair enough? I'm not sure what she meant. If you can expand your question, or maybe if Cosima, you want to write a little bit more, because I'm not sure what you were asking.
Yes, can you listen to me?
Yeah.
Okay, my question
Yes.
was about, like you were talking about if some models from machine learning can be, or can have a kind of bias, right? And it presents many issues in healthcare application. I was wondering, how do you guarantee, how do you measure if one model is good enough for healthcare?
Well, I think you do it the same way like you would when you implement any other decision support, right? You start thinking about how is this expected to affect my patient population? Am I expecting to see a difference in race, gender, location? Am I expecting those? And what are the outcomes that I anticipate? And compare them to what you have before decision support or with the existing decision support you have. And I think you just do your evaluation study like you would do with any other decision support that you'll introduce, except that you have to keep an eye on the factors that flow into your model and see if any of those have an effect that introduce a bias toward a particular patient or provider group or a specific location. So yeah, good evaluation studies are needed for decision support that we come up because we just implemented a clinical guideline, just as much as you need it for machine learning. But your point is actually very good, because oftentimes it's hard to anticipate where the bias might sneak in. And unless you know what you're looking for, it's hard to find. So evaluating machine learning algorithms is actually trickier, because you actually have to throw a wider net in order to find all the things that might be influencing it. So yeah, it's going to be, I'm sure Dean will come up with a model of how to do that safely going forward too.
Yeah, I was just going to add, Chris, that, I'm always, I don't know, shocked or surprised when I get a group of people together and tell them about the great idea I've had. And usually it only takes 4 or 5 people in the room, and someone says, what about this? Did you think of this? And I'm like, I can't even believe that we forgot that. And so I think if you have some good, smart people that know about healthcare, and you have to be able to trust them and trust that they're not trying to hurt you, but they're trying to help you, and then ask them, what could go wrong with this? What am I doing? What am I missing here? Because, when you're building these models, you're doing your best and you think you're doing a great job. I mean, everyone's trying their best, and sometimes you forget things. And, I'm always shocked when I get the reviews back from my papers, how insightful the reviewers are in just a few short minutes, how they can see the weakness in the paper that I couldn't see for the 6 months that I was working on the project. And so I think that we're going to have to subject our AI algorithms to these same sorts of, rough, honest rigor, and not say that, anyone that says your algorithm's bad, not that I'm a Luddite or I don't like AI, but I'm just trying to be honest. And I think we're going to need to do that.
Yeah, I have 2 things that I want to respond to that. So number one is, I have never built decision support without breaking something in the process. And luckily, I have never killed anybody in the process. But there's always the possibility. So that tells you about the inherent danger if you implement something that you actually don't understand the mechanism for. And the other thing that I want to say is, humans, you heard me say that earlier, another thing that humans are really good at is pattern recognition. And throwing what you built and decision support out to humans, they will quickly discern if there's a pattern or something that ain't right. That is really the beauty of, as what Dean pointed out, by having this peer review process work out, because they will quickly narrow down. They will see that. A machine would never identify that, but a human will quickly target on that and find the thing that will break the whole model. So, and there are some people who are particularly good at that. Find those when you're building your decision support.
Good. We have 2 more questions and then we will close the session. One was a little bit earlier, but Lucas Mueller was asking, which is the role of the MD in the design of a EHR? And I would like both of your opinions, one that is an MD and one that is not an MD.
You want to take that first, Dean?
No, I missed the question. I was.
What's the? It's in the chat. Okay. What's the role of the physician in the design of the EHR?
Oh.
So let me start out with this. I have known Dean for, I don't know, probably 20 some years. And I'm also reminded of another PhD who does decision support, and that's Adam Wright. And what I've learned over the years is that people can accumulate an enormous amount of knowledge about healthcare processes, of the way work is conducted without being an MD. And the more important thing is I have learned over the years that informatics is a team sport. The thing that I'm proudest of, actually, everybody has their ego wall, right? So the certificate I'm most proud of is a special project pharmacist certificate that I once got for working well with the pharmacists. And that was, I thought was a great achievement. I believe that nobody, not the MD, not the nurse, not the pharmacist, not the decision scientist, not the person who writes algorithm, is sufficient to develop good decision support. It's a team effort, and it requires the knowledge and expertise of people that come from various backgrounds and skill sets. That said, selling it to physicians is probably best done by another MD. Because physicians can be incredibly righteously indignant and give you grief about things that they perceive affecting their workflow. And having a physician champion helps with rolling it out to physicians. The same is true with nurse champions for nurses, although they're less obnoxious than physicians are. All right, I'm going to stop here and let Dean answer.
Dean, would you like to announce?
That was very good. I think back on my career, and when I've been successful, I've had a good physician partner. When I haven't been successful, I've had to do it on my own. And, so much of having a partner is having someone that you can trust and someone that'll give you an honest feedback. And so even when you're doing the wrong thing, they've got to be able to tell you, that's really not working. And, I remember I've been working on a paper with my advisor from my PhD like 30 years ago, and it's just been accepted about some of the work that we've been doing. And he's been continuing that work for the last 30 years. And I saw this old screenshot, and I remembered the first time I showed that screen that was going to pop up on a reminder to a clinician saying that, you should adjust the ventilator. And I was trying to be a fancy programmer at the time and put stars all around my answer that would come up on the screen. It was a character-based screen. And somehow I made a mistake in the coding. And so when I showed it to him in the ICU, instead of putting the stars around the thing, it started ringing the bell on the computer. And he was very calm, and he just looked at me and he goes, "I'm not sure those bells are necessary," And he didn't even, he said, I like that recognition that, you're going to increase the FiO2 on the ventilator and, perhaps put the patient more at risk. And he just says, I'm not sure we need those bells. And, he didn't say it in a mean way, like you idiot or anything. I was feeling really bad because I wanted the stars to come up so nice. And I think you need the clinicians to give you that real world feedback on what they're trying to do and what's working. And so, like Chris mentioned, Adam and I both have spent a lot of time working with clinicians and spending time in the ICU. And I think anyone that's building these systems needs to work and be right with the doctors for a long period of time to just sort of see how they work. I'm always shocked how doctors work. Like I can't even stand up for more than an hour at a time. And they stand up for like 10 hours. And then you think about, like, I was thinking about how we're using this computer and they're standing up. Like I always sit down and use my computer and they have to stand up and use it. Just that kind of thing changes the way you build your computer systems.
Wow, great. I love being with you guys. You make it so easy chatting with you. I really miss you. We have one last question. What aspects should you take into account for selecting the data set to train AI algorithms?
I'm going to take a first step on that, if you don't mind, Dean. I am not somebody who does a lot of AI. I have people I work with that create the algorithms. But I think it's the same things that you need to consider is when you think about issues related to big data. You need to have an adequate volume of data so that you can actually draw a conclusion from it. Your data actually should have a certain degree of velocity. So that means they should change over time so that when you rerun your models that you see changes in behaviors or changes in recommendation. Your data should be have a great variety. The more factors you can bring into the model, the more likely you are to actually find the one factor that will drive your model. And it has to have a certain veracity and value as well. So the same things that you consider when you think about big data is what you should think when you build in algorithms for your clinical processes. I'm gonna see if Dean has something to add.
No, I like all those things. I think I'm reminded of a paper talk I heard John Halamka give one time. He was telling about someone who was trying to predict, bad test results. Like when should you order another CBC on a patient? And lots of people have tried to reduce the number of tests that are ordered. And someone ran this thing and said, it turns out all the tests that are ordered around 4 in the morning are really low or really high values. And he said something like, well, that makes sense. That's when patients are the sickest. That's when no one's awake in the hospital. It's just a bad time all around. And so somehow you have to have someone that understands the data and what it means, because so many times, like I've looked in the computer and thought that I was seeing some data. Like I did a project with a fellow once and we were looking at potassium values in the NICU, and we found a whole bunch of ones that were like life-threatening potassium values, and we thought, and no one's doing anything about them. And it turned out, they were hemolyzed samples, and that wasn't in our data set. That was in a free text field, and we didn't download that. And so you really have to understand what the data means. And I know that so many people in AI try to say, oh, that stuff all comes out, just throw everything in there, it'll be okay. And that doesn't work. I'm not sure how to say that other than it doesn't work.
And I have to share a funny story after that, a story that Dean just shared. I was sitting in a meeting and we were talking about decision support. I was there with internal medicine doctors, surgeons, and I'm a neonatologist. I'm used to these high potassium values. And I said, oh, I don't care unless the potassium is at least 6.5. And somebody turned around, looked at me and says, yeah, that's because you're a bad doctor. So that's what I got from that. That was somebody who didn't understand our workflow. So
exactly.
And somebody asked for my email. I put it in the chat.
Thank you once again for being here. I know you had to take time off work. You're Christian call. Dean, you must be also working.
Yeah, I must have a job, right?
Yeah, definitely. You should have. So it was a great pleasure that you were able to join us in this virtual conference. And we're looking forward to see you back again in person real soon.
I have to do one more thing. Dean, you did vote today, right?
We voted 3 weeks ago. We're a mail-in state.
All right.
So
All right.
okay.
You did your job then.
Yeah, thank you.
Thanks for having us.
Yeah, thank you, Paula. It was great.
Have a nice day, all of you. Bye-bye.
Okay, bye.
Bye-bye.
Ciao.
Ciao.